everyone. So for today's installment of EBM, we'll be talking about measures of association. I'm Hannah. Thank you to Dr. Zehtabchi for his help with this case. So in order to learn about measures of association, we will use an example from the New England Journal. So this was published in August 2023, right when my class started residency, actually. Looking at video versus direct, seeing which method is more successful for intubation. And despite what I thought going into this, because of the prevalence of video at King's, like worldwide, only 20% of intubations are done with video. So there's no conclusive evidence on which method is preferable. You can pick various studies on the matter, and the only multi-center study showed no difference between the two. So the authors were looking at whether direct intubation would be less or more successful than when you use video, with the hypothesis that video would be more successful. So first pass intubation is the primary outcome, and then for secondary outcomes, they were looking at any significant event between induction and 2 minutes after intubation. So hypotension, hypoxemia, or cardiac arrest or death. So as a very large study, there were 17 sites. These were both emergency rooms and ICUs. Patients were randomly assigned. Inclusion criteria was if a patient required intubation. And exclusion were prisoners, pregnant patients, or people who had anatomical or like medical reasons that they couldn't have one method or the other. So, this is kind of like egotistical, but I put the 3 stars where I thought the most important numbers were. So about 70% of the patients in the study were intubated by emergency medicine physicians. Of those, most were residents, and the median number of intubations performed by the operators was 50. You see the IQR is pretty wide, so fairly large variability in the operators themselves. So randomization based on the size of each site, patients were, a preset number of patients were enrolled at each center, and then the allocation concealment meant that until the patient was enrolled, the operators wouldn't know which method they would use. Obviously, you can't fully blind this because half of the operators are going to know what they're using, hopefully. It's also worth stating that they didn't really control for any pre-oxygenation or induction methods. So there was a lot of heterogeneity in the intubations themselves, but there was someone in the room watching this, determining if there was a first pass intubation. And the results used intention to treat, so patients enrolled were used in the denominator, regardless of whether they received the pre-specified method of intubation, and follow-up period was only 2 minutes after intubation. So I will step aside.
Good morning, everyone. Unfortunately, our EBM time slot and conference has been shrinking significantly in the past few years. So in the near future, we actually have created some ACGME approved EBM pills that in the future, you just take a pill before you're coming in and you're done with your EBM training. The point of this lecture is to talk about effect size and how you present the numbers that show the benefits or harms of a treatment, what we call the measures of association. The effect size are basically the magnitude of benefits or harms. How much of a benefit is useful to you, how much of the harm is concerning to you, and this is the part of the research that helps you make clinical decisions, right? There are a couple of ways to present the effect size. Because the lecture has to be short, I cut a few things that are less used. but we will talk about relative risks, relative risk reduction versus absolute risk difference, and we'll talk quickly about number needed to treat and number needed to harm. Risk is relatively easy if you assume that there's a dice. I learned that dice and die now you can use interchangeably, so I'm not worrying about it. If you have a dice and you roll that dice, the risk of having a 1 is 1 out of 6 options, right? So the risk of having a 1 or chance of having a 1 is 1 out of 6, which is 17%. And if you have 2 dice and you throw both of them, the risk of having one dice compared to the other dice is 17% in one, 17% in the other one. So your ratio of the 2 risks is 1. In this case, the risk of disease is the same in dice 1 compared to dice 2. And if you, in one dice, the 2 of the options represent the disease, and in the other dice, 1 option represents the disease, the risk in one is 2 out of 6, the risk in the other one is 17. And again, relative risk or risk ratio, which is the ratio of the 2 risks, will be 2, right? It's relatively easy. The relative risk is the ratio of 2 risks, the risk in the the risk in the study group divided by the risk in the control group. So we'll talk about this a little bit more. This is a made-up example. You have 2 groups, an exposure group or a study group, and you have a control group. In both groups, you have 100 patients. Outcome occurs in 10 patients in the exposed group, and outcome occurs in 12 patients in the control group. The risk in the exposure group is 10 out of 100. The risk in the control group is 12 out of 100, 10% versus 12%. Relative risk or risk ratio is the ratio of these 2, right? So it will be 10% divided by 12%, and that's 0.83. So 0.83 or 83% means whatever the risk is going to be in the control group, the risk in the study group will be 83% of that, right? If 100 people die in control group, 83 people are going to be dying in the study group. A relative risk of 50% means 10 people die in the control group, 5 people are going to die in the study group, right? 60% again means if 10 people experience the outcome in the control group, only 6 people are going to experience the outcome in the study group. So that's what the relative risk means. You can extrapolate and guess what percentage of people in the study group are going to experience the outcome if you know the risk in the control group. So that's relatively easy. That's what relative risk is. Probably the easiest way of expressing the effect size is absolute risk difference, as it means what it means. You have 4 out of 12 patients in one group versus 8 out of 12 patients. 8 that's 16. 4 out of 16 versus 8 out of 16. 50% experience the outcome minus 25% experience the outcome. Just the absolute difference between the 2 groups. This is the easiest way, the most intuitive way, or most honest way to present your data, right? The risk in one group minus the risk in the other group. That's your absolute risk reduction. That's your absolute risk difference. And that's what you have to use when you present your numbers. So again, relative risk was the ratio of 2 risks. What is the meaning of relative risk of 25% or 0.25? Meaning that whatever the risk is in the control group, the study group, only 25% of people in the study group are going to experience that outcome. Now, we're going to introduce you to another concept, and that's relative risk reduction. When you think about relative risk of 1, we use relative risk of 1 as a reference. Relative risk of 1 means the risk in the study group is the same as the risk in the control group, right? That's what we use as a reference, as a point of reference for a drug or for an intervention that doesn't work because the risk of outcome is the same in the both groups. So your relative risk means that now you have efficacy. The risk is less in patients after you did the study, right? And relative risk means basically represent how far did this intervention rob the relative risk from a useless relative risk to an effective relative risk. That's relative risk reduction. It's a very odd concept. It's difficult to understand. Doctors don't understand it. Almost impossible to explain it to the patient, but there is a purpose to it. It's not wrong, but there's a purpose to it that we will discuss. One of the downsides of relative risk reduction is you can get a very high number, even with very, very small difference between the two groups. If you look at this case, the baseline risk could be 1%, the treatment group risk could be 0.4%, and that when you do the calculation, you get relative risk reduction of 60%. Or the difference could be huge, and you can still get that 60%. So relative risk reduction, you need to know the baseline risk. We'll come back, we'll look at this again. So just quickly, most people, most patients, and even most doctors think that you have a disease, there's a treatment for the disease, you give it to patients, and the disease goes away, right? That's what you think. You take your kid to the doctor, and they test for strep, and you get antibiotics, and the strep is supposed to go away. In reality, that's not how it works. In almost every treatment, there's a group of patients who will benefit from that treatment, and the disease will go away. There's a group of patients who will not benefit from it at all, and there's a group of patients who will be harmed by it. This is a concept that is foreign to a lot of people, right? Every treatment has three outcomes. Some people will benefit, some people will be harmed by it, and some people will have neither benefit from it nor be harmed by it. And the ratios are different, right? Some treatments are more have more benefit than harm. Some people are more harm than benefit. Will you ever use the third row treatment? It depends on the disease, right? If you have a malignant, really aggressive cancer, and the chemotherapy might offer you a very toxic chemotherapy with a lot of adverse events, might offer you a slimmer chance of benefit, you might choose it, right? So everything here we talk about is outcome, disease-specific, outcome-specific. And, you know, this is Zithromax for URI, right? Nobody benefits, only harm. Most people know. So when you, if you keep that format in mind, that every disease has benefit, harm, no benefit, number needed to treat will tell you exactly how many patients do you have to treat to get that green part, how many patients do you have to treat to get that red part, and then how many patients are going to be in the no benefit, no harm zone, right? Wouldn't this be useful to know? And it's kind of easy, intuitive to explain to the doctors and to the patients. So that's why we like the idea of number needed to treat. And in this case, the absolute risk difference from the previous example was 2%, and number needed to treat is 1 divided by absolute risk difference. Another good reason why you should always calculate absolute risk difference. And it's easy to calculate. And 50 means you have to treat 50 people with this treatment, whether it's an intervention, it's a drug, or whatever it is, for one of them to benefit. And this is benefit that is outcome specific. So you say, I have to treat 50 patients with this to prevent 1 death. I have to treat 40 patients to prevent 1 hospitalization. I have to treat 20 patients to prevent 1 MI, right? It has to be outcome specific. And you will be surprised when you look at the NNTs and NNH, you see, even the treatments that we think are highly effective, you rarely get, anything less than 1 in 20 or 1 in 10. And the number needed to harm is the same thing. Basically, the ratio of people who are harmed by in the placebo group minus the people who are harmed in the study group, the difference, the absolute risk difference between the two, 1 divided by absolute risk difference will give you how many patients do you have to treat for one of them to develop diarrhea, for one of them to develop a rash, or one of them to experience any kind of harm. All right, are we good with this? Excellent. Now let's just do some numbers. This is one of my favorite papers. I'm sorry if you have seen this before. This was a study done by a pharmaceutical company. They looked at all kids who had physician-diagnosed flu. I don't know how that is done, but physician-diagnosed flu, and ended up having physician-diagnosed pneumonia, right? They divided these two groups into who got Tamiflu, who didn't get Tamiflu, right? So they want to see how Tamiflu reduces the risk of pneumonia after flu. Now, if you read the abstract, it's perfect. It says overall, children who received Tamiflu for the treatment of physician-diagnosed influenza were 52% less likely to be clinically diagnosed with pneumonia at a subsequent medical encounter. And the relative risk is 48%, right? Which means whatever the number of the risk of pneumonia is in the control group, the risk in the study group is 48% of that. When you see that 52%, it's a very impressive number. If I'm a pediatrician, if I'm a family physician, internist, I have a child with flu, I am going to prescribe Tamiflu. 52% less likely, not bad, right? But let's look at the numbers. They usually, this is the table that they provide. They have the risk, basically you can calculate the risk in, let's look any pneumonia. So the risk in the study group will be 29 divided by this total N. The risk in the control group will be this divided by this number, right? So the risk of pneumonia in the study group is 29 out of 44, 47. Risk in the control group is 279 out of 20,407, right? This is easy calculation. Your absolute risk reduction is 0.75%. So this is a problem. If I'm a pharmaceutical company that I'm going to the doctor's offices or to the hospitals to sell my drug, I'm going to tell them, if you prescribe Tamiflu, it will reduce the absolute risk of pneumonia by less than 1%. That's not going to sell, right? But we got to come up with a plan. So now you do, and the NNT will be 133. So you have to treat 133 patients with Tamiflu to prevent 1 pneumonia, which is a clinician-diagnosed pneumonia. It doesn't mean even that requires treatment, doesn't mean that causes hospitalization, could be completely a fake pneumonia, 133. But again, the drug has to sell. So we calculate relative risk. Remember, relative risk was the risk in the control group, study group divided by risk in the control group. You get a relative risk of 0.46, and relative risk reduction, it will be 1 minus relative risk. It brings you to 54%. Now you're golden, right? Now the 54% is a big number, even though you had absolutely nothing here. First of all, this should tell you that pneumonia after flu in PIDs doesn't exist. 1. 2, even if you treat them with pneumonia, doesn't do anything. But you can play with relative risk number and get a big number. And doctors don't understand that this is relative risk reduction and it doesn't mean much. And for the hospitalization is the same, but I want to show you this. This is how they came up with the relative risk reduction of 54%, is how far the treatment pushes a relative risk of 1 to 46%. the relative risk reduction, what you need to remember is a measure that is used to exaggerate the effect size. So when you have nothing, you can use relative risk reduction to exaggerate it. And if you remember the abstract that I showed you, did you see anywhere that says that number 51.7% was relative risk reduction? Accidentally, by mistake, yeah, they dropped that. So they said risk, but it was actually relative risk reduction. So a lot of things that you read in the abstract of the papers, and they say it reduces the risk by 89% or 95%. Those big numbers are actually relative risk reduction. If you do the numbers yourself, which is not really difficult, and you calculate the absolute risk difference, a lot of time you see the difference is really minuscule, is nothing. Even the big reputable organization do this. This is about probiotic and how it can prevent C. diff diarrhea. It says a probiotic reduced the risk of C. diff diarrhea by 60%. That's a really, really good number, right? Now, the risk in the probiotic group was 1.5%. The risk in the control group was 4%. The absolute risk difference was only 2.5%. So if you give your patient probiotic, you reduce the risk of C. diff diarrhea by 2.5%. I'm not arguing that 2.5% is not a big number, especially given how many millions of people take it, but 2.5% is more honest number. The number needed to treat is 40. So out of every 40 patients on antibiotic who take probiotic, only one of them is going to you can only prevent diarrhea in one of them. And when you calculate the relative risk reduction, it's 60%. Now, 2.45%, not sexy enough, 60%, great, right? So relative risk reduction is for exaggerating the numbers. This is the NNT.com. You can go to NNT.com, especially this is great for when you're working clinically, you don't have time to do literature search, you don't have time to look for systematic reviews. You can look for whatever treatment you want. We usually use a very reputable, robust systematic review as the source. We calculate absolute risk difference. We calculate NNT and NNH, and you can use this to quickly find an answer to your question. Like in this case, corticosteroids for sore throat. If you look at this traffic light rating system, green means benefits are more than harm. Yellow means we need more data. Red means the harms and benefits are almost the same. Black means the harms are more than. So when you look at something green, you got your answer. This is a treatment that works. And again, this is outcome specific, reduction of pain or whatever the outcome is. If you look at the absolute risk reduction, actually this has to be absolute risk difference. From the systematic reviews, because they do a lot of adjustments, adjust for sample size, adjust for heterogeneity, the systematic reviews or meta-analysis, they have to give you the absolute risk difference. You cannot just deduct the risk in the two groups. If you have one RCT, one paper, you can do that, but for systematic reviews, they have to calculate it and give it to you. And whenever a relative risk crosses one, remember relative risk of one means what? The risk is in the study group and control group is the same, so the treatment doesn't work, right? So every time the confidence interval for a relative risk crosses one, that treatment, that difference between the two groups is not significant. You don't really need a p-value when they are giving you a relative risk with 95% interval. All you need to do is look at the confidence interval, the 95% confidence interval. If it crosses one, the treatment is not effective. Therefore, you're not supposed to calculate the number needed to treat, because if the absolute risk difference is 0, 1 divided by 0 is infinite. So if only calculate the NNT if the absolute risk difference or relative risk is statistically significant. All right, sorry for rushing through this. Yes.
That was great. And
Thank you.
I learned my lesson with this a few times. The drug companies all the time prefer with new drugs to use the relative risk.
Of course.
And they'll show it out front because they want you to buy it or prescribe it. So you always have to think of not just the relative risk, but absolute is more important than NNT. You also have to think of NNT minus the NNH to the side. And one of the things I remember that we've talked about in the past and you helped me with is with Paxlovid.
Yeah.
Right? When you look at Paxlovid, it looks great when you do a relative risk. I mean, it looks wonderful, right? But when you do it with absolute risk reduction, especially if you take in consideration young, healthy people or people who've had vaccinations, it isn't really that great. And of all the COVID I've seen, I've only used Paxlovid 3 times, only because it was older people who were at big risk and they didn't have a contraindication. Like, I think the one time you were going to use it, you couldn't use it because they had a contraindication of the drug they were on, and they were going to have a reaction with the drug they really needed.
Yeah.
So be very careful. The drug companies will do this all the time, and then they'll advertise it on TV.
Correct.
Still, you'll see Paxlovid on TV all the time.
Nowadays, there's no, the pharmaceuticals can directly put ads on TV and social media without any permission, asking for any permission or without any vetting. They can. So even Pfizer did the second study on Paxlovid that they sat on it for 2 years because they were making $4 billion every quarter. They sat on the data for the Paxlovid, the second study that included vaccinated people. Even though they knew the Paxlovid didn't work, they had to terminate the study because it was supposed to test whether patients getting hospitalized or dying, and nobody was dying or nobody getting hospitalized. But they sat on it for 2 years. If you read the paper, the Paxlovid papers, as Dr. Gernsheimer said, the relative risk reduction is like 89%, and 99% of people only read the abstract, and very few people go to the tables and just do. It takes 2 minutes to do the calculation yourself. But if you only read the abstract, you're going to see that 89%, 94% big numbers that are made out of nothing. So you just have to. Don't read the abstract. Look at go to the table. It takes 2 minutes to calculate the absolute risk reduction and NNT, and that's all you need.
So we'll take the 2 minutes to do the honest calculation based on what we just learned. So going back to the study, to use the terms very literally, the exposure in the study is video. The control is direct intubation. We see that the quote unquote risk of a successful first pass intubation using video is 85%. That risk is 71% for direct. We calculate the absolute risk difference. We see that there's a 14% difference between the two. And then we calculate our NNT, we say 1 over that 0.14. We get 7.14, you can't treat 0.14 of a patient. And so the honest calculation for a number needed to treat, you round up dollars. So for every 8 patients who are intubated with video, 1 of those patients is successfully intubated who wouldn't have been in the control group. I will spare you that reading for these two, but basically, so for operators who perform fewer than 25 intubations, the absolute risk difference for them is 26%, which is really significant. And then the number needed to treat is just 4. So in contrast to the 10, the 20 that are like typically found for people who have not performed many intubations, using video is associated with much higher risk of first pass success. That difference disappears when you look at the most experienced operators. Initially, you see an absolute risk difference of 5% between those 2 groups, but the confidence interval crosses 0. And so even though it tends towards quote unquote higher risk of first pass success, there's no significant difference between the groups. And then secondly, the secondary outcomes, the severe complications, cardiac arrest, death. There is a 0.5% absolute risk difference between the two methods. But again, the confidence interval is roughly even and there's no significant difference between the two. So had there been some significant difference here, we would say there's like a number needed to harm versus a number needed to treat. So in conclusion, the study found a higher first pass success rate using video, but the benefit was pronounced among those less experienced operators as opposed to those with more experience. So no difference between adverse events in the two groups. And I would say for us, given that there's no difference in the secondary outcome of harm, it would point towards the need for us to perform enough direct intubations that we can be in that group with equal success rates for both. So